First and foremost, I would like to thank the organizing committee for the invitation. It is a pleasure and a great honor for me to be here giving the lecture. I would like to underline that this is a collaborative work with colleagues working at St. George's Hospital in London, with whom I want to share this honor. Coming back to the speech, I would like to start with a small preamble. Some years ago, we thought that the hemodynamic progression in fetal growth restriction included an initial increase of the umbilical resistance, followed by a phenomenon of cerebral vasodilation, brain sparing, followed by an increase of resistance in the aortic isthmus, and finally, an increase of resistance in the ductus venosus with a reversed or absent A wave. If we consider the interval to labor or fetal death, we saw a typical progression, which was 4 weeks for the umbilical artery Doppler, 3 weeks for the MCI Doppler, 2 weeks for the aortic isthmus Doppler, and finally 1 week for the Doppler of the ductus venosus. In this regard, the problem was not the diagnosis, but the prematurity. If prematurity was predominant, we had to prolong pregnancy. If Doppler anomalies were severe, ending the pregnancy was mandatory. But this unitary concept was challenged a few years ago, when some fetuses at the end of pregnancy were reported to present a normal umbilical artery Doppler plus an abnormal MCI Doppler and an adverse perinatal outcome. What happened was that within the group of small 4 gestational age fetuses, there were in fact 2 different groups. The first included fetuses particularly below week 34, with a peak at week 27 and an abnormal umbilical Doppler. And the second included fetuses particularly after week 34, with a normal umbilical Doppler and an abnormal MCI Doppler and CPR. And more strikingly, these anomalies in the CPR and MCI Doppler continued growing from week 34, despite there being no anomalies in the uterine or umbilical Doppler. What happened was that there were in fact 2 different entities: early onset and late onset fetal growth restriction. In the first, a reduction of functional villus surface causes a decrease of placental function and a subsequent abnormal umbilical Doppler. In the second, late onset fetal growth restriction, a late onset supply-demand imbalance causes cerebral vasodilation and a subsequent abnormal MCI Doppler. In the first group, the progressive hemodynamic anomaly gives rise to a progressive weight loss. Conversely, in the late onset group, as a notable weight may already have been reached, a small 4 gestational age fetuses might coexist with fetuses presenting normal weight. That's what I call apparent appropriate 4 gestational age fetuses. And these small 4 gestational age fetuses and apparent appropriate 4 gestational age fetuses herald this imbalance with a vasodilation of the cerebral arteries. Therefore, while in early onset fetal growth restriction, physiopathology revolves around the umbilical resistance, in the late onset variety, it revolves around the cerebral vasodilation caused by a lack of nutrients that the fetal brain detects despite the placenta being nearly normal. Here we can see how any fetus may present late onset fetal growth restriction whilst being appropriate for gestational age. The fetus on the left presents growth restriction, but it grows in the upper centiles. Therefore, growth restriction does not make it cross the 10th centile, thus remaining as appropriate for gestational age. Conversely, on the right side, we have another fetus that presents the same restriction, but because this fetus is growing in the lower centiles, growth restriction does make it cross the 10th centile, thus becoming small for gestational age. And this explains the particularity of late onset fetal growth restriction, that we can find appropriate for gestational age fetuses with cerebral vasodilation and adverse neurocognitive outcome, whose placentas present smaller volumes, smaller cords, less vessels, less villus units, and poor responses to vasoactive substances, and therefore, very important, seem to be designed for fetuses with a lower growth potential. But these apparent minor dysfunctions are important because they can cause subtle anatomical and functional neurological damage that we can see, for example, by measuring the insula or the corpus callosum or several metabolic ratios. And can also cause cardiac anomalies with hearts that are abnormally programmed, becoming bigger and globulous with systolic and diastolic dysfunction, as we will see in the next presentation. So, this is the reason why we want to diagnose and detect late onset fetal growth restriction, but also because after week 34, and in coincidence with the advent of late onset fetal growth restriction, there is an increase in the incidence of stillbirth. And this stillbirth, although many people think that this stillbirth is more frequent in small for gestational age fetuses, it isn't. In fact, it is more frequent in appropriate for gestational age fetuses, as you can see here in this slide. And this is another slide that shows the same data, with data coming from the King's College. As you can see, most of stillbirths are appropriate for gestational age fetuses. So, if weight is not a reliable parameter, then we should look for a different approach. The parameter that best fits the physiopathology of late onset fetal growth restriction is CPR, cerebroplacental ratio, because it reflects the imbalance between fetal demands and placental supply. And also it presents a high sensitivity, being positive even though the components of the ratio present borderline values. Therefore, considering the CPR, we propose an alternative model based not on fetal weight, but on fetal hemodynamics. If we plot in a graph weight in centiles and CPR in multiples of the median, we're able to see two different models for diagnosis. On the left, we have the weight model that selects fetuses with a birth weight below the 10th centile. On the right, we have the hemodynamic model that selects fetuses with a CPR below a special threshold. The threshold, you can see here, of 0.67 is the 5th centile of those fetuses that we considered that are growing optimally. This is to say, over the 19th centile. The advantage of this novel model is that it put the spotlight on a very special group of fetuses, those with normal weight and abnormal CPR. Because these fetuses, regardless of fetal weight, are more likely to present adverse outcome. For example, as you can see here, they are more likely to present abnormal pH at labor. And also, they are more likely to present cesarean section and instrumental delivery at labor as well. But not only our group, but other people, other investigators all around the world, for example, in this case in Australia, have seen that this special group of fetuses with normal weight but abnormal CPR are more likely to present adverse outcome at labor. For example, as we see here in the slide, they have 3 times the risk of cesarean section for fetal compromise, and twice the risk of fetal compromise diagnosed at any time during labor, and 2 times the risk as well of pathological CTG patterns during labor. So another question to ask is which parameter relates best with adverse outcome, birth weight or CPR? The answer is that the association is better for CPR. For example, in relation with admission to neonatal unit. This is another example of comparison between birth weight and CPR. In this case, we use a mathematical model that resembles the isobars of an atmospheric pressure map. The change of pH is stronger for CPR, and is stronger because the change is stronger from top to bottom, following the CPR axis, and not from right to left, following the birth weight axis. So we were very happy, and we published these findings in the White Journal. Fetal cerebral redistribution was a marker of compromise regardless of fetal size and better than fetal size. But then, some papers which came from the King's College were published, and they were right. And they said that one thing was the association with adverse outcome, and yet another aspect was the predictionability of adverse outcome. In fact, the predictionability of CPR is low, and it is even lower when the interval to labor is more than 15 days. But even though CPR is best associated with adverse outcome than birth weight, both models taken separately are poorly predictive. So it might be that the most intelligent approach was to combine both models. Here you can see an example of combination of CPR and birth weight in relation with pH. The area with lower pH, the area that is more likely to have a low pH, is here in dark blue, and is situated where abnormal values for CPR and abnormal values for birth weight merge. Conversely, the area with less risk for a low pH, in red here, is situated where normal values for CPR and normal values for birth weight merge. So, if we know that CPR is the best parameter associated with adverse outcome, if we also know that birth weight below the third centile by itself, even in fetuses with normal Doppler, is a marker of adverse outcome, for example, cesarean section for a normal CTG, neonatal hospitalization, and adverse neurocognitive outcome in the long term. If we also know that there are late onset placental anomalies that are reflected in abnormalities in the uterine Doppler that can only be visualized at the end of pregnancy, then it might be that the best approach was to combine all the parameters, CPR, uterine Doppler, and fetal biometry, and create a model to which new parameters might be added in the future. Another question to ask is, when is the best moment to perform the examination? The best examination is performed when the interval to labor is lower, is shorter. Therefore, it's logical to see that the prediction is better at 35, 37 weeks than at 30, 34 weeks. And in turn, the prediction at 30, 34 weeks is better than prediction done at 20 weeks. So let's do the prediction at 24 weeks, or at 42 or 41 weeks at the end of pregnancy. But we can't do that because we may lose the ability to predict adverse outcome at term. So it might be that the best moment to do the prediction would be probably between 35 and 37 weeks. In practice, this approach works because at least in the small fetuses, we are able, combining all these parameters, we are able to predict adverse outcome at term, at least in the small fetuses. And in a recent paper, we were able to predict stillbirth with a detection rate of 70% with an area under the curve of 0.88. And this was done by combining the three parameters. Although it is true that this paper was done with a low number of pathological cases and in a population, in a high-risk population. Finally, we have a third example of combination of Doppler and fetal biometry for the prediction of adverse perinatal outcome at 37 weeks. As you can see, detection rate for CPR is low. It's only 23%, for a false positive rate of 10%. It is not high, I know. But it's better than fetal weight, which is only 19%. But the most interesting thing is that by combining fetal weight and fetal Doppler, we increase the detection rate to 30%, which is not high. I know it's not high, but it's better than any parameter alone. So, prediction of adverse outcome with several parameters combined needs a little help. And it might be that this help might come from the use of biological markers. In this regard, some of the most promising biological markers are mRNA and microRNA, as they can predict how the fetus is growing. They can also predict fetal hypoxia in utero, and also some of them, like microRNA 132, present a tight correlation with spine density and learning capacity, and can also be detected in serum. So in theory, they might be used to monitor fetal brain networking in situation of chronic hypoxia. So in conclusion, 1, low CPR is a marker of adverse perinatal outcome, regardless of fetal weight and better than fetal weight. 2, CPR examination is at least advisable at the end of pregnancy. 3, single measurements cannot predict adverse perinatal outcome. 4, by combining weight and Doppler, we obtain models with diverse prediction abilities, which are still low, I know, but better than any other approaches. And 5th, future biological markers might increase the prediction ability of ultrasound. Thank you very much.
So, thank you so much for a wonderful and very clear presentation, and congratulations once more on being awarded the Stuart Campbell Lecture for this year. Well done.
Thank you very much. Thank you.
Just before we introduce the next speakers, could I get one of the AV team, please, to come here and reset our timer, because it seems not to be working.
Thank you, Aris, and thank you for brilliantly chairing the scientific committee over the last years. I look forward to continue over the next year to work with you. And that brings us to the top 5 abstracts of this Congress. This year it was a record high in numbers again. We received over 1,200 abstracts, most of them of very good to excellent quality. And we could only select 5 of the top abstracts. It's actually not we, it's the scientific committee, it's the reviewers, and I would like to thank the referees for this, because they scored at least every abstract was scored over 3 times by different referees, and this gave us the final score, and this was used to select the top abstracts, and now we will see the 5 top abstracts, and then you have oral presentations and the poster presentations, but this comes later. So I would like to invite the first presenter, and this is Dr. Fatima Kispi, and she will speak about fetal growth restriction that induces different phenotypes of cardiac remodeling.